We're now recording, so that you know that, and people, as I said, will continue to come in. Fortunately, if you watch this, or unfortunately, if you're watching this from home, now you're seeing what's going on in the room. So you're seeing in the corner. I might shut, or at least pause that if it's messing up your screen. We can get rid of it. But at home, they can see us. But the recording doesn't capture the person. It captures the screen, which is why all you're seeing when you're doing YouTube is what's on the screen, and you're hearing what is hopefully a reasonably good sound. And I've worked pretty hard at trying to get good sound. It's not as good as I would like it. But I usually start these off as close to on time as I can with an introduction, so that if you're clicking on this as a YouTube or as a video file, you'll know who you're about to hear from. We have First Friday every month. For those of you who've come before, every month, the first Friday of the month, we host events, and we've been really fortunate to have a lot of folks from the outside. This month, we're really fortunate to have our brand new dean, who's just arrived and said yes, foolish lady, that she would do this within the first month of being here. I'm going to be really sparse on the introduction because it takes away, and she'll tell you more about herself, I'm sure, and why she'll tell you about the talk and the work that she's done. But Marcia Gardner is new to Molloy College. She is our dean in the Barbara Hagan School of Nursing. She comes to us most recently from Seton Hall. What I like to be able to say is she's a kindred spirit to me because she is, in fact, a pediatric nurse. So we kind of find each other from around the country and the world. And what I forgot to take this morning, but I do have, if she would allow me, is the book that she is the co-editor of. And I think she'll tell us about that in the talk as well. But I did have that available if people would like to check it out. I won't leave it down here because we can't trust that they don't walk in this room. So with that as a really brief introduction, I'm going to get her started so that she can have her stuff and be ready to only push the next slide. And like I said, the best way of doing this is the down arrow, because otherwise it's hot. Thank you. Marcia Gardner.
I'm really thrilled to be here. And as a few of you may know from running into me in the hallway, I am kind of passionate about talking about developmental vulnerability and developmental disabilities because in nursing education and in clinical practice, we're not as prepared, perhaps, as we ought to be to understand disabilities in general. And perhaps some of you read, in 2010 to 29, on 2012 also, maybe some of you read Suzanne Smeltzer's work on, nursing students and disability and nurses and disability. And she had a great article in the AJN, I think it was in 2012, about nurses' attitudes in taking care of people with disabilities. And what she has reported and what we see across nursing curricula is that we really don't integrate very much about disabilities care in general. We're not the only clinicians who have that gap. Most healthcare providers in medicine and nursing have limited, say, competencies in caring for individuals with developmental and intellectual disabilities and with disability in general. To be honest with you, our colleagues in dentistry are actually way ahead of us when it comes to, preparing clinicians for best practice use in clinical practice, in the primary care office, across different kinds of healthcare settings. And Dr. Smeltzer was at last year's BSM conference that was sponsored by the ACN, talking about, again, the need to integrate disabilities and disability issues better into nursing education. I've been talking about it for quite a number of years too. In 2012, I put a little piece in the Nursing Clinics of North America. There was an issue about nursing education, talking about where we were, and where we haven't really changed very much. So I think that's kind of a starting point for this. Ronnie mentioned about my book. the University of Pennsylvania had a very innovative certificate in autism care for nurses. They had a federal grant, and as part of the grant, one of the outcomes was to write a book. And so Ellen Giorelli, my colleague at Penn, approached me and asked me, because I have a pediatric background, she's more of an adult person, about editing this book. And what's very innovative about it, and I think it's very important for us to realize, it's a lifespan book. And that's very unique because most information about developmental disabilities, and as you'll see, most people's comfort level in developmental disabilities really is in pediatrics. But all of those individuals, kids who are diagnosed as children, will become adults. And so we need to think about what kinds of competencies nurses across settings and across educational levels need, basic competencies and basic understanding. So that's kind of where, my starting point really is about this issue. And I hope you'll indulge me that I always like to take a couple of minutes to just give people a little background and update about autism in general, to demystify it, and just for everyone to be on the same starting point about what we know as recently as we possibly can know it. So I'm going to throw in a little bit about autism in general and changes in the diagnostic process and these kinds of things. But
let me clean your screen a little bit. Give me one
okay,
second.
sure.
So I can make it where you can actually have a full screen. I forgot to shrink this guy down. I'm going to shut it off, and I'm also going to hide this guy. In around the early 2000s, I guess you could say, maybe from about 2004 to 2009, there were a few studies that looked at health status of individuals with developmental and intellectual disabilities. And no surprise, but health status is very poor in people with intellectual and developmental disabilities in general. There are access issues, there's stigmatization, there are myths about individuals with developmental and intellectual disabilities that are held by healthcare providers. That's a little bit out in the literature. It's very hard to get a handle on how many, what is the size of the population, because most of this is state-level data, and states define these things somewhat differently, and so forth. We don't really have a national clearinghouse in any way. That being said, a couple of more recent studies, a 2016 scoping review that was by Williamson and her colleagues, a 2014 systematic review, a 2017 assessment of Ohio state-level data. Not much has changed. Not much has changed. Still many barriers to access to care, still problems with communication, still stigmatization, still myths on the part of healthcare providers about what individuals with these kinds of challenges are all about. Still, individuals with developmental disabilities and intellectual disabilities less likely to have a primary care provider, less likely to have equal health status to other individuals without these kinds of disabilities. So 10 years later, it doesn't look like very much has changed. Why is that? And I guess our assumption and our hypothesis, you could say, is we're not doing the best job possibly in getting the information to the beginning clinicians and kind of growing their knowledge. And when I talk about beginning clinicians, I'm talking about nurses at every level, not only entry into initial practice, but also about advanced practice nurses, about clinical nurse specialists. I'm talking about everyone. And we're also thinking about that issue of a kid becomes an adult. What does that mean? And so, we think about those kinds of issues. And in addition to that, where is this information in nursing curriculum? And you'll see some of our data from the survey that we did of nursing faculty across a variety of levels, and think about your own curricula and where things are in your own curricula, because I pretty much believe that you probably see a lot of the same kinds of issues in your own curricula and our own curricula here. It's a very common kind of challenge because where do you fit it?
How do you do it in a way that is reasonable and feasible when there's so many other issues that we have to address? You know, a couple of years ago, a few of us proposed some sort of basic competencies for the care of individuals with developmental disabilities, building on the Society of Nurses in Developmental and Intellectual Disabilities competencies, thinking about tailoring them a little bit more. So we can talk about that later.
Click in the middle of it. You have to get the clicker and make sure that you're in the middle of the slide.
Okay.
Yeah, click there, and then it'll go.
So, you know, the literature also tells us that nurses are not particularly comfortable with people with intellectual and developmental disabilities, and a lot of negative attitudes about individuals who have behavioral atypicalities and challenges. There's not a lot of recent literature about this. Here and there's sporadic investigations into what's happening. And I find it interesting because autism, as I guess you could say a model of a developmental disability, has been in the lay literature, has been in the professional literature quite a bit. Quite a bit. And it's interesting to me as to how we've maybe gotten a little bit stuck in our thinking about these kinds of challenges. Autism is a spectrum disorder, and there's an enormous range of behavioral presentations. There are enormous range of different responses that individuals have to the stimuli that they experience in the environment. And so, you know, our catchphrase is that to know a kid on the spectrum is to know one kid on the spectrum. And that's one of the biggest challenges that we have. By the way, does anybody know who those babies are? I'll tell you at the end. Those are the Dion twins. Remember them? Mm-hmm. The very first, you know, known, you know, naturally born quintuplets. Anyway, so I just wanted to talk a little bit about autism. As I said, I always try to take an opportunity to help people to understand a little bit about autism and autism spectrum disorders and what we currently know about it. So, you know, in ASD, it's a spectrum of behavioral manifestations and so forth. Autism is diagnosed by observation. Right now, we're not at the point in any way of making any kind of biophysical diagnosis. But it is a group of developmental disabilities with these three core features: social interaction impairments, communication impairments, and restrictive and stereotypic kind of patterns of behavior, very rigid kind of thinking, rigid responses, difficulty sometimes accommodating to changes. And these are the kinds of behaviors that clinicians in general practice often find very challenging to accommodate to. You know, it's very interesting to me also because when people think of individuals with autism, you know, they tend to think of one of two extremes. One is that very severely impaired individual, maybe some of us who are, you know, from a different generation of nursing education. Maybe you're thinking about, you know, what you learned in your initial nursing education program, flapping and rocking and, you know, watching the opening and shutting of the mini blinds. And then at the other extreme is the exceedingly high functioning individual, you know, the Albert Einstein type of person. There's been a lot of interesting discussion about, you know, who had Asperger's syndrome and so forth, who are these people. But there's a huge range of individuals in the middle, you know, in the middle. And when I teach about autism to students, I often show them videos and say, pick up the child who has an autism spectrum disorder, you know. And they're often surprised to see who that child is, because in some ways those kids don't look a very lot different than other children. But it's their reactions and responses to certain kinds of experiences that kind of differentiate them. So it's kind of interesting to think about that. So, what do we know? We don't know. I'm sure that you all know all of this, but lots of things that were thought to possibly be related or associated with autism have been debunked as causes of autism. And, most scientists, believe that there's an epigenetic kind of causative process, and we don't know exactly what that is. There have been many, 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 many genes that have been identified as associated with autism. There are syndromes where there are autistic-like behaviors. There's relationships in terms of neurotransmitters with other kinds of processing disorders and so forth. It is associated with some kind of perinatal events. We do see a higher incidence in preterm infants who have certain kinds of perinatal events. It is associated with advanced parental age. It seems to be more associated with advanced paternal age than advanced maternal age, and as I said, lots of syndromes and all the various things that have been debunked. We really don't know. We really don't know. This is the old diagnostic criteria. I just want to bring this up because we use these terms a lot, even though it's not the official diagnostic procedure anymore. So in 1993, the diagnostic criteria for autism were redefined way more broadly in the DSM. It's the DSM-4R. And ended up kind of looking like this. We're under the autism spectrum diagnosis. There were 3 categories: autistic disorder, that's the classic autism, Kanner's autism, pervasive developmental disorder, not otherwise specified. We can't really put a finger on it. A lot of kids who are diagnosed with atypicalities are often placed in that category first, and then Asperger's syndrome, which we would say is very high-functioning autism, and different kinds of diagnostic criteria for why that is. And this is pretty much the way things spread out. I can see that very, very well. But this is PDD, pervasive developmental disorder. The majority of children who are diagnosed fall into that category in the beginning. Asperger's syndrome down here, about 10% of kids who are in this particular categorization. And then more traditional autism as autism spectrum disorder. And things have changed a little bit. This is the way it looks now. There was a lot of controversy over redefining the autism category, but basically under the autism spectrum disorder umbrella, okay, are 3 levels of severity, no longer autism and PDD and Asperger's syndrome, but now basically based on whether or not there's a language impairment, there's an intellectual impairment, and whether or not it's less or more severe. So I don't know if you're seeing out in clinical practice, people are still using the old diagnostic categories. I'm much more comfortable with that, but there are some. I was talking with a psychiatrist colleague of mine in New Jersey recently, and he's using the 2013 diagnostic categories now to get a lot of pushback from the families and so forth, because families are very concerned about making sure their children in particular were still eligible for the services that they really needed. And so this is the most recent prevalence data that we have. The good thing is that there was a very rapid rise. I'll just go back down to this slide for 1 second. I'll just find it here. There's a very rapid rise in the prevalence from about 2000 to 2010, and it seems to have leveled off some. So the last CDC data, which was reported in 2016, which goes up to 2012. So they're a little bit behind. But so the last prevalence data was unchanged, still 1 in 68 8-year-old kids. Right? And there's a lot of variation by state. New Jersey, in the last set of CDC data, had the highest autism prevalence in the country. Prevalence, of course, 1 in. So we had 1 in 42. That's a huge, huge number. Why that is, I don't know. But the majority of kids are in kind of regular schools and also are receiving healthcare services from generalist kinds of clinicians, not from specialists in autism. There aren't very many aren't very many.
Yeah, let's use the mic.
Oh, sure.
The mic doesn't help.
I'll talk louder. I got excited. I kept, so I'll talk louder. But we still see some disparities because, up until very recently, probably about 10 years ago, children who came from underrepresented minority populations were less likely to receive an autism or a PDD diagnosis and more likely to receive an intellectual disabilities diagnosis. So I think that's kind of leveled out some, but not 100%. There are still, racial disparities in the way that the diagnosis is applied. And, again, this comes down to training our students, educating our students about what all of this means. And, there is a male to female gender disproportion that in the high functioning population in particular, it's about 5 times more boys than girls, but girls are increasingly being diagnosed with an autism diagnosis. Now, just kind of as a sideline, my colleagues and I did a very interesting, not this group of colleagues, but did a very interesting little study. It was kind of an incidental data set that got created, I can tell you that story at another time, of women with Asperger's syndrome and their experiences in childbearing, what it was like for them during the, peripartal kind of experience. And when I talked with, colleagues and we would talk about how we were analyzing the data, and so many people would say, like, what? There are no women who have this diagnosis. It's all boys. Where did you find women with this diagnosis? So, again, I think there are some misconceptions that we need to address in our curricula about that. So we already talked about this, about this data, so I'll just pass over that. About 50% of kids with diagnosed with autism have an associated intellectual disability. It is hard, as we all know, to evaluate intellectual and cognitive capacity in individuals where there are communication issues and those kinds of things. But that means 50%, about, give or take, don't. And again, that's a myth. So, and then the other thing that I think is very interesting and exciting is the whole idea of the neurodiversity movement. And I found this one kind of interesting. There's a dating site. There are many different kinds of advocacy websites and so forth. There about 6 or 7 years ago, there was a little blip of women writing about their own diagnoses of autism and so forth. And there's a, you can take the AQ, the autism quotient, and see if you have tendencies in one way or another. It's all over the web. And I think that the autism advocacy community is posing the question: what about neurodiversity? Why are do we need to change, or do you need to change your thinking? And I think that kind of comes down to the whole idea of disability, and working from strengths versus working from people's challenges and limitations. So that's my, I guess, that's my framework for talking about autism. And I don't know if everyone watches ever The Big Bang Theory and so forth, but people think Sheldon is modeled after an individual on the spectrum. There was a movie. What's the actress's name? The one who's in Homeland.
Claire Danes.
I'm sorry?
Claire Danes.
Claire Danes, who, played Temple Grandin. That was about 5 years ago. I don't know if anyone saw the movie Adam or the movie Jane Wants a Boyfriend. They are recent films about relationships and, kind of the normal development of young adults. And the protagonists are people on the autism spectrum, representationally, I don't know. TVs, and I watched The Good Doctor. Okay, and did you see the movie The Accountant? Because these are all, very interesting representations of the wide range of behaviors. But I will say this much: while there is a lot of optimism and hope, about 50% of adults who are diagnosed with an autism spectrum disorder and are high functioning, or what we would say, high functioning, or defined as Asperger's syndrome, are not employed. So we need to change, the social world a little bit, culture as well. So sort of with that big context as to why I guess this is important to me in understanding how nurses and other clinicians, think about autism to a small degree. And I know it's not the typical review of the literature. My colleagues and I did a national survey of nursing faculty to find out what they thought and how comfortable they felt in integrating concepts around autism spectrum disorders and best practice evidence to care for people across the lifespan into nursing curricula. So it was an online web survey. We plugged it in through SurveyMonkey, and we randomly sampled nursing education programs across the country, and we used the U.S. territories, but no one responded from any of the territories outside of the United States. So I ended up with about, I think, 48 states where I had some responses. I use both the NLN and ACN websites because I wanted to tap people who taught in all kinds of nursing programs. So these were programs from LPN through, DNP and Ph.D. programs. And then you'll see, the majority of people finished the survey, but we did analyze any data that was submitted. And in order to qualify for, to be in the sample, the individuals had to be licensed nurses, any level, they taught in the LPN program. They had to be in a current faculty role teaching in a nursing education program. So if they taught in a medical school or something like that, they didn't qualify. So we ended up with 295. 78% of that group were also in some kind of clinical teaching role. So some of them taught only in the classroom, some of them taught only in the classroom, some taught only in clinical, some taught both. And 50% of our sample were in current clinical practice. So this is a little bit more about the sample. You can see that the majority of faculty taught in, associate degree or generic or accelerated BSN programs. About 60% of registered nurses in the United States are prepared initially at the associate degree level. So, actually, I was expecting a few more. Highest level of education, the majority masters in nursing, and then you can see some of the other, very few BSN. I didn't get anybody who was only prepared at the LPN or diploma level. Some DNP, some PhD. And, the majority had a good amount of experience in nursing education. And the reason I think it's important to see this is because, comparing this to the national data on nursing faculty, this is pretty much what the nursing faculty across the country looks like in terms of their educational preparation, where they teach, and what their how long they've been teaching. So I felt like, it did suggest something about the trustworthiness of our information. And this is important also, you'll see in a little while why we asked this question, but we also asked them if they had any kind of personal relationship with an individual on the autism spectrum. And about 35% said that they did. I'll just say, when I have gone to present about autism in a variety of different kinds of settings, when I first started, I would say how many people, have some kind of personal connection with an individual with autism, and nobody would raise their hand. One or two people, yes, I know someone. Now when I go, almost everyone has, a 1 or 2 or 3 degree relationship with someone on the autism spectrum. But it was kind of significant, as you'll see in our data, for a variety of reasons. So the majority, knew somebody, had a friend. So we also asked them to reflect back a little bit on their own education. And this is very messy data, but, about the trustworthiness, because people, it could have been 20 years ago, it could have been 30 years ago, it could have been 4 years ago, 5 years ago. But in the majority of people, learned a little bit about developmental disabilities or about cognitive impairment, but really very little about autism or anything that they could remember. And then we talked about what's going on in your own class, in your post-licensure education, your APN education, clinical or specialist education, whatever, you know, how much information do you remember? Not that much. Not that much. And clinical experience as well. You know, no one had a great experience or had lots and lots of experience. Even, you know, when we looked, we weren't able to sort out the data all that well in terms of all the different specialties because we didn't have enough representation from every single specialty. But we were able to look at pediatrics, psych, community, and even, you know, even pediatric nurses and so forth hadn't had a lot of learning experience themselves. But I thought this was a very interesting finding. In the past 5 years, did you have any continuing education about autism spectrum disorders? And again, if you think about the context, how much, you know, you read in the newspaper, you know, 5 or 6 years ago, there were just endless articles about the, you know, epidemic of autism and so forth, and yet very little, you know, very few in our sample had any kind of continuing education on autism, and, you know, there are lots of reasons that that might be. And then we came to, you know, the survey questions that I think were very interesting about how do you feel about your ability to teach and model for your students some best practices. So we asked them how, you know, how much basic information they felt they had about autism in general. And you can see that the majority felt that they had kind of good basic knowledge. There was a pretty, you know, nice little group here who said, I really know very little. We asked about behavior strategies, and this is, of course, important because understanding behavior helps you to provide appropriate, high-quality, effective health care for people. So understanding about behavior and how to help your clients to accommodate their behavior, to tolerate it, and so it's very time-consuming to, you know, work through some of these things with individuals. And again, you know, the majority felt they had some good basic knowledge, very few expert knowledge, you know, but a good clump of our sample felt they really didn't have very much knowledge or any knowledge at all. And then the medication side. So these are all psychoactive medications and commonly used medications, anticonvulsants, medications used to treat attention deficit problems, nothing that is a specialized medication that a generalist would not feel comfortable with. And yet you can see how many in our sample did not feel very knowledgeable about medications used with people with autism, even though they're not unusual meds. So the reason I, you know, pointed out before about the issue of relationship is because a lot of our findings were significant by relationship. It was more likely for people who had a relationship of some sort with someone on the autism spectrum that they felt more comfortable in one way or another. And additionally, you know, a lot of our findings were significant by specialty, and, you know, we asked for their clinical specialty and so forth, they're certified in a particular clinical specialty. And, you know, I think the important finding was that people who had an adult specialty were significantly less likely to feel that they had pretty good knowledge, that they had an understanding of behavior strategies. We asked a question about counseling and referring, and you know, this group of our sample really were very uncomfortable. And it's as we expected, because the focus has been on pediatrics. And, you know, those in psychiatric practices or community interface in a different way. But that 1 in 68 children, 8-year-olds, who are diagnosed are going to become your patients in the hospital. They're going to be in the emergency department. They're going to be in the perioperative suite. They're going to be on the med-surg unit. They're going to be in your primary care practice. They're going to need immunizations. They're going to need, you know, a cardiac workup. They're going to be there. And they probably are there already, but you probably don't even recognize that they are. So I think that to me was, as I said, unexpected, but a very important finding that can help us in thinking about how we prepare our students for clinical practice. And we asked a question about where they got their information. You know, where did you learn about best practices? And so you can see that, you know, the majority, 25, 27%, I think it was, didn't feel like they had learned anything. They didn't even think about best practices. And then, you know, a wide array of kinds of things. But, you know, here back to your nursing program, your education program, very few are reporting that they learned anything about best practices. And there are best practices now that are out there that can help us to make the experience of healthcare less traumatic, more effective, improve health status of, I would think, is a very vulnerable and challenging population to work with, and also a population that is a time-intensive population that, of course, affects productivity metrics and other kinds of problems. We asked a question about how they perceive their attitudes about caring for individuals with autism. You know, how difficult do you think it is to care for a patient with autism? And remember that a good portion of our sample were in current clinical practice. Most people, you know, were on the it's a little more difficult than it's a little more easy kind of side. And I think that, again, it informs our thinking about how we can help people to make it a little more comfortable. And how comfortable, we asked about their level of comfort in caring for a patient, engaging in the following kinds of interventions. So how comfortable would you be as a clinician establishing a therapeutic relationship with someone on the autism spectrum, interpreting their communication, helping the person stay calm, performing a painful procedure, an immunization, putting an IV, something like that, explaining treatments, sort of, you know, pre-procedure kinds of explanations, managing autism-specific kinds of issues, de-escalating behavior, counseling a family member, supporting a family member, and referring families to appropriate resources. And you can see where, you know, the line is with 3 being comfortable, 3 or higher being comfortable or very comfortable, that the majority of the sample were not comfortable with any of these. You know, not that they're not doing them, but it suggests that more support could be useful. And then again, all of these were significant, again, by personal relationship and by specialty. So if you had a personal relationship, you tended to be more comfortable. If you're in pediatrics, psych, or community, you tended to be a little more comfortable. If your specialty is adult care, they tended to be less comfortable. And then how well prepared do you feel about teaching your students these kinds of things? And again, people don't feel very comfortable doing it. And certainly autism spectrum disorders they don't have the prevalence that a lot of other kinds of conditions have. But I always think, even in my pediatric course, does anybody teach pediatrics, undergraduate or graduate? How many hours do you spend talking about the congenital heart defects? And that is definitely not 1 in 68 kids. You know what I mean? You probably spend 4, 5, 6 hours talking about that. You probably spend an hour talking about developmental disabilities. But nurses are way more likely to encounter those kinds of challenges and conditions and patients who need support and help out in clinical practice, then unless you work in a specialty hospital, you're not very likely to take care of a child who has, you know, tetralogy of Fallot or, you know, any of the other kinds of congenital heart defects. So this I found was very, very interesting. We asked this only of clinical teachers. How likely are you to seek out patient care experiences, any level of clinical education from LPN through APN? I just want to find my data here. So of that group, half of them said we asked a question about how important they thought it was to provide their students with clinical experiences with individuals on the autism spectrum. Half of them said it was very important, you know, somewhat important to very important. Half of them said it was, you know, important or very important. Yet how many people do it? right? Because when you have to make the choice of what kinds of patient care experiences your students are going to have, you know, they're choosing other kinds of experiences for a wide array of reasons. You know, for a wide, and we certainly didn't ask those reasons, but you know, you can think about what are, you know, some likely reasons. And certainly in APN practice, I mean, you're seeing who, you know, who comes in the door. And then we ask some questions about, you know, in your own curriculum, what do you currently do? How much autism, you know, specific kind of content do you have in your program? And remember, these are people who teach across a wide array of things. It was more likely to be found in pediatrics, way less likely to be found in any other course, So no discussion whatsoever. None. That was a lot of people teaching who are focused more on adult care. So it's just interesting to think about that. And then pre-licensure and so forth. So, you know, but the challenge, of course, is how do you fit this in a world where there's so much curriculum creep and there's so many kinds of disorders that we have to address. And I think that's a challenge for all of us to think about. And I think it, in some ways, you know, in pre-licensure education where, you know, we have simulation and we have lab opportunities and those kinds of things, to layer in different kinds of conditions and characteristics and those kinds of things, is a little bit easier. But I think we have to think about something beyond only teaching about these conditions in pediatrics, because the management part of it is going to enlarge in areas where people are caring for adults. So, sort of that being said, I'm happy to talk about it or answer any questions.
What I'd like to do, I'd like to pause the recording. Everyone, please say thank you at this point. Yeah.